Hello everyone, today we will talk about different types of renal tubulopathies, the so-called renal syndromes. So these are a group of autosomal disorders characterized by either loss of function mutation or gain of function mutations on different types of channels or transporters on the renal tubules, resulting in electrolyte disturbances. So we will go across with starting from Bartter syndrome through Gitelman syndrome, Liddle syndrome, and we will go across to the end with Fanconi syndrome. So to start with Bartter syndrome is an autosomal recessive disorder of a loss of function mutation of the receptor where the Lasix or the furosemide act on, which is the so-called sodium, potassium, and 2-chloride co-transporter. So this co-transporter will not work regularly and it will lose these electrolytes like the Lasix or the furosemide do. So at the end, it will result with hyponatremia, hypokalemia, hypochloremia, every hypo of electrolytes. So this will in turn result in the initiation of the RAS system, and it will result also in increased renin as well as aldosterone effect at the end. So the second one is Gitelman syndrome. In the Gitelman syndrome, it's also an autosomal recessive disorder with loss of function mutation of the channels at the level of the distal convoluted tubules. These are the sodium chloride channels where the thiazide diuretics acts on. So it has like that of the thiazide like diuretic effect, and it will result in this sodium and chloride will not be reabsorbed. They will come across through the urine. So the cumulative effect is just like that of the Bartter syndrome. But the main distinctive feature of this Gitelman syndrome is it is highly associated with severe hypomagnesemia, which is also a cause for refractory hypokalemia. It could be. The third one is Liddle syndrome. This Liddle syndrome is the autosomal dominant disorder which is characterized by gain of function mutation of the ENaC channel or the epithelial sodium channels at the level of the collecting ducts where the aldostrones act on. So it is just like that of the aldosterone-like effect where there is no increased level of aldosterone. The aldosterone level is normal, but the ENaC activity is overactivated. It is over or gain of function mutation. So what will happen here is there will be excessive sodium reabsorption with water in the blood with respect to excessive secretion or excretion of the proton and the potassium. So it will result in hypokalemia, metabolic alkalosis, and also the hypernatremia with hypervolemia. So later on it will have a negative feedback on the aldosterone system. So we can treat it by like the amylorides and others blockers for aldostrones. So the other one is the Gordon syndrome or the pseudo-hypoaldosteronism type 2. So it is just a direct oppose of the Gitelman syndrome. So what here happens in Gordon syndrome is there will be a gain of function mutation which will result in overactivity of the NAC channels at the level of the distal convoluted tubules. So there will be excessive reabsorption of sodium together with water, and it will result in hypervolemia and hypertension. So there will be hypertension here, but there will be normal or low blood pressure in that of the Gitelman syndrome. So hypertension will be seen both in Liddle syndrome as well as with the Gordon syndrome. And the fifth one is pseudo-hypoaldosteronism type 1, which is a direct opposite of the Liddle syndrome, where there will be a loss of function mutation of the ENaC channels. So there will be the direct opposite effect with hyponatremia, and there will be hyperkalemia and acidosis will be there. And the last one is the Fanconi syndrome, where the effect here is at the level of the proximal convoluted tubule, where most or majority of the reabsorption takes place. So there will be the bicarbonate reabsorption will be affected, and it will result in bicarbonate urea. So there will be alkalotic urine, and it could result in acidosis. The type of acidosis here is mainly type 2 renal tubular acidosis. So if you talk about renal tubular acidosis, so Fanconi syndrome is one of the major examples for type 2, where the bicarbonate excretion will be more, or the bicarbonate reabsorption will be affected, and there will be type 1 as well as type 4 renal tubular acidosis. In type 1, there will be proton secretion affected. So what happens is the proton will not be secreted and it will be retained. So it will result in renal tubular acidosis type 1. So in renal tubular acidosis type 1, it's mostly due to some drugs like amphotericins. For renal tubular type 4, and it's mainly associated with the aldosterone effect. So the aldosterone effect on the receptor will be affected. So it will result like the hypoaldosteronism like effect, like that of the acidosis and hyperkalemia, whereas the hyponatremia will be there. So these are all about the renal tubulopathies, or the so-called renal syndromes. And if you have a comment, you are welcome. Thank you very much.